was also supposed to mention that everybody should go visit the exhibits, and at 10:30 will be the drawing for the Apple EarPods. So our next speaker is Dr. Vinay Sundaram, who's the Assistant Director of Hepatology at Loma Linda, and Cedars. And he's going to be talking about cholestatic liver diseases, PBC and PSC.
Okay, thank you, Dr. Khan, for inviting me to speak at this conference. My topic will be updates and an overview of both PBC and the PSC. These are my disclosures. So I know that we have people of varying degrees of training and experience, so I'm going to provide an overview of both diseases as well as provide updates. PBC, now known as primary biliary cholangitis for the last couple of years, is an immune-mediated destruction of the small intrahepatic bile ducts, and that's one of the differentiating features from PSC. It's a female-predominant disease. The female-to-male ratio is around 10-to-1, and the diagnostic criteria are based on meeting 2 out of the 3 per the AASLD, which is cholestatic liver enzyme elevation, which indicates alkaline phosphatase liver elevation predominantly, presence of a positive antimitochondrial antibody, which has a sensitivity of around 95%. About 5% of patients do have what's called AMA-negative PBC, and in those patients, it's not always easy to determine if they have PBC, but one of the blood tests you can use to determine that is an IgM, which is elevated in certain patients who have PBC. And then finally, liver biopsy evidence of destructive cholangitis, also known as a florid duct lesion. So again, a liver biopsy is not necessary if they meet the other 2 criteria. It should only be considered if you suspect the disease, but their antimitochondrial antibody is negative, or if you're trying to rule out other concurrent diseases. In addition, all patients who you're suspecting PBC in should have imaging to rule out extrahepatic disease. Physiologically, what's occurring with PBC? So it's all based on the immune injury to the bile ducts. And as a result of this immune injury, you get malformation of the bile ducts and destruction with bile duct loss. Now, what happens is that the bile ducts are the mechanism by which bile acids are supposed to flow out of the liver and into the intestine. And subsequently, you get accumulation of bile acids. And it's this accumulation of bile acids which then leads to further destruction of bile ducts as well as to development of liver fibrosis, which then can lead to cirrhosis and end-stage liver disease. So really, the best way to treat PBC up to this point has been bile acid therapy, in other words, to reduce the bile acid pool accumulating in the liver. The standard of care, I'm sure many of you know this, is ursodeoxycholic acid, also known as ursodiol. And this is a naturally occurring bile acid which inhibits intestinal absorption of other bile acids, increases biliary secretion of bile acids, and reduces ductal inflammation. It's administered at a dose of 13 to 15 milligrams per kilogram, and it's supposed to be in BID or divided doses. Now the problem is that not everybody responds to ursodeoxycholic acid. And depending on what you read, it can be up to 40% of patients do not respond to ursodiol, though in my clinical practice, I find it to be more around 20 to 30%. The other problem is that there's no clear consensus on how to determine if a patient has responded to ursodiol or not. And I've highlighted 6 scoring systems, none of which has really been promoted as the gold standard scoring system. But I'd like to review some of the strengths of each of these scoring systems with regards to simplicity as well as accuracy and robustness, and then let you know which one I prefer. So the first 2, the Mayo Clinic and the Spanish criteria, these are probably the most simple. The Mayo Clinic is just a decrease in alkaline phosphatase to less than 2 times upper limit of normal after 6 months of ursodiol therapy. And the Spanish criteria is just a reduction in alk phos by 40% from baseline after 1 year of therapy. So these are very simple to memorize. My preference, however, are the Paris criteria, and either the Paris 1 or Paris 2 are good criteria. For both of them, the patient needs to be on ursodiol for a year. So that's one thing to note, is that in order to determine non-response, the majority of these criteria require 1 year of ursodiol treatment. What I like about the Paris criteria is the incorporation of both the alkaline phosphatase and the bilirubin, and I'm going to highlight in a little more detail why I think incorporation of both of these markers is relevant. The other one I want you guys to take a note of is the Toronto criteria, which is a decrease in alkaline phosphatase to less than 1.67 times the upper limit of normal. The reason why this one is relevant is because this is the criteria used in the POISE study to determine which patients should be eligible for obeticholic acid, which I'll also review in more detail. This is one of the landmark studies which evaluated which markers are the best indicators of response to ursodiol therapy. It was a meta-analysis of over 4,800 patients. The overall characteristics of the patients, majority were middle-aged females, 12% had cirrhosis, 85% were treated with ursodiol. Now in this particular slide, these are among all the patients who were treated with ursodiol, and it looks at the different markers and how they reflect transplant-free survival. So I'm going to go through each of these individually. So the first one looks at alkaline phosphatase alone, and as you can see, alkaline phosphatase of less than 2 times the upper limit of normal as compared to greater than 2 times the upper limit of normal indicates better transplant-free survival. Similarly, if we look at bilirubin, which is normal as compared to abnormal, which is just even greater than 1 times the upper limit of normal, a normal bilirubin has a significantly greater transplant-free survival. Now, graph C, which I think is the one I want to highlight the most, looks at the combination of bilirubin levels and alkaline phosphatase levels. And here's what I want to highlight. The first 2 graphs indicate both alkaline phosphatase. The first one is alkaline phosphatase less than 2 times upper limit of normal, and the second one is alkaline phosphatase greater than 2 times upper limit of normal. However, in both of these situations, the total bilirubin level is within normal limits. And as you can see, the survival is different between the 2, but not vastly different. Now, if you compare it to this group of patients here below, where they have alkaline phosphatase both less than 2 times upper limit of normal and greater than 2 times upper limit of normal, the abnormal bilirubin, regardless of the alkaline phosphatase level, still indicates a poor prognosis. So my point with this is make sure to incorporate not only alkaline phosphatase level, but also bilirubin level to determine if the patient is responding to ursodiol therapy. The GLOBE PBC score is the most robust scoring system and probably the most well-validated scoring system available. However, it's not as simple as the other ones I've highlighted. This was validated based on a meta-analysis of over 4,000 patients, and it incorporates a number of variables, all of which are readily available, but you have to go into this website and plug all the numbers in order to get a 15-year survival. All of the patients who were studied were patients who received 1 year of ursodiol therapy. So it's a very good scoring system. It just may be a little bit cumbersome. But here's again what I wanted to highlight. If you look at all the variables incorporated into the GLOBE PBC scoring system, the 2 variables individually which have the hazards ratio towards transplant or mortality are the total bilirubin and the alkaline phosphatase, which goes back to my previous point. These are really the 2 markers you want to pay attention to in order to determine is the patient responding to ursodiol therapy. Now, it's been well established that non-responders to ursodiol therapy have a reduced transplant-free survival. This was a very recent study published earlier this year, which also looked at the incidence of hepatic complications. This was a study of over 3,000 patients, all of whom are treated with ursodiol. And what it established was that at about 15 years of follow-up, the incidence of cirrhosis-related complications, which are ascites, encephalopathy, and variceal bleeding, was around 15%. This was in the entire population. If we break down the population into subgroups of biochemical responders and non-responders, and they use the Paris criteria to determine biochemical response, the cumulative incidence of first complications was significantly higher in the non-responders. So again, indicating not only that there's reduced survival, but also a greater incidence of cirrhosis-related complications. Can you predict which patients will not respond to ursodiol? So this was a cross-sectional study from the UK PBC cohort of 2,200 patients approximately. And all the patients were on ursodiol for a minimum of 2 years, and they used the Paris 1 criteria to assess response. And what their findings was that 80% of the study cohort did have a biochemical response, so it was the majority. Men tend to respond less so than women. It was around 80% versus 72% when you compare men to women. And the one key point is that patients who present with PBC at a young age, less than 30, are the ones who tend to respond the least. Now, I've only seen one of those patients, so you're not going to see this commonly, but if you do see a patient who's presenting under the age of 30, only 50% of those patients tend to respond to ursodiol. So I've established how to look for ursodiol non-response and what the consequences of ursodiol non-response are. What can we do for these patients? So many of you are probably familiar with obeticholic acid. So this is a farnesoid X receptor agonist or FXR agonist. And this is data from the POISE study, which was their major clinical trial. These are the baseline characteristics. What I want to highlight here is that among the patients who received placebo versus Ocaliva, that the alkaline phosphatase at baseline was similar. 90% of patients in all the study arms were using ursodiol, so very few numbers of patients were ursodiol naive. And here were the results. If we look at, focusing mainly on 12 months of therapy, what they did was they had a total of 3 arms in this study. They had ursodiol plus placebo, ursodiol plus Ocaliva 5 milligrams, which was then titrated to 10 milligrams after 3 months, depending on response, and then obeticholic acid at 10 milligrams plus ursodiol. And what they found was whether you received ursodiol as part of the titration starting at 5 milligrams and increasing, or you received 10 milligrams starting at the beginning of study enrollment, either way the response to treatment was around 40%. So among ursodiol non-responders who enrolled in this trial, over 40%, close to 45%, had a response to receiving Ocaliva. And their mechanism for determining response was using the Toronto criteria, which I highlighted before, which is an alkaline phosphatase less than 1.67 times upper limit of normal, along with normal bilirubin. So in summary with obeticholic acid, the dosage is 5 milligrams daily. If after 3 months there isn't an appropriate response, then you can increase it to 10 milligrams daily. Now keep in mind a few important side effects. Number one was that among patients who received obeticholic acid, there was an increase in pruritus. In the study, these patients were treated with cholestyramine or other anti-itch medications such as antihistamines. There's also a reduction in HDL levels, though that has not been correlated with cardiovascular outcomes. And also very importantly is that there is a risk of worsening liver failure among patients who have Child's B or C cirrhosis. And that's very important because if you are going to treat a patient who has Child's B or C cirrhosis, then you need to give them a different dosage of 5 milligrams weekly to a maximum of 10 milligrams twice weekly, depending on their tolerance. So I mentioned in the POISE study that over 90% of the patients were receiving ursodiol. What about for patients who are intolerant to ursodiol? Can you give them something as monotherapy? So this was a study published earlier this year by Dr. Cowdley in Seattle, and it was a randomized controlled trial looking at obeticholic acid monotherapy. So they had a total of 59 patients receiving placebo, obeticholic acid 10 milligrams daily, or a higher dose because there was no ursodiol of obeticholic acid 50 milligrams daily. Treatment was for 3 months, followed by a 6-year open-label extension. And what they ultimately found was that the greatest benefit was among patients receiving obeticholic acid 10 milligrams. And the reduction in alkaline phosphatase from baseline was around 54%. The main reason for withdrawal from the study, however, was pruritus, which was around 15% in the obeticholic acid 10 milligram arm and 40% in the 50 milligram arm. So what the lesson from this is that you can give this as monotherapy. I would not start at 10 milligrams daily. Rather, I would, if you are giving it as monotherapy, I would give it according to the package, which is 5 milligrams, then titrated to 10 milligrams. But it does seem that for patients who ultimately get to 10 milligrams daily, that there is a good response if they're ursodiol intolerant. The other class of medicines I want to highlight for the non-responders are the fibrates. So these are medicines which improve PBC based on PPAR agonism as well as pregnane X receptor agonism. This slide highlights some of the smaller studies, and the medications which have been studied include bezafibrate and fenofibrate. Bezafibrate 400 milligrams daily, fenofibrate 145 milligrams daily. These are all relatively small studies. However, published earlier this year was the Bezerzo trial, which is one of the largest studies evaluating the use of bezafibrate plus ursodiol in ursodiol non-responders. So they had a total of 100 patients. Their biochemical response was based on reduction in alkaline phosphatase, and normalization of bilirubin, and they also looked at improvement in fatigue, pruritus, and quality of life. And in this graph, we have the results. The yellow bar indicates the response to treatment with a combination of bezafibrate and ursodiol, and from 15 months and beyond, there was a 30% or greater response rate among those patients who received the intervention. The blue bar represents the response rate among people who got ursodiol plus placebo. The reason why you don't see any blue on this graph is because nobody receiving the placebo had a response. And what's important to highlight here, these are the adverse events among both study arms. And what is interesting here is if you look at the percentage of patients who had pruritus, among the patients who received bezafibrate, it was 8%, which was actually less than the patients who received placebo. So it's an indicator that bezafibrate may also be helpful in alleviating pruritus. The other things to highlight is that there was one patient who had a rise in creatine kinase level, as well as a patient who had a rise in creatinine levels. Now, these were only 1 out of the 50 patients, but nonetheless, these are things to be aware of if you choose to prescribe this medication. Primary sclerosing cholangitis. So this is another immune-mediated destruction of the bile ducts, but it includes both intra and extrahepatic bile ducts. Diagnosis is primarily by cholangiogram. MRCP is good enough, and ursodiol, as many of you know, is not recommended for this disease. It can be given, but if it is given, it should be only given at medium doses, and high doses has been studied and is found to increase the risk of adverse events in this disease. Many of you do ERCPs, I assume, so what is the definition of a dominant stricture? Now, I'm not an interventionalist, but this is taken from the AASLD guidelines, that a dominant stricture, which is found on an MR cholangiogram and does require ERCP intervention, is defined as a stenosis leading to a narrowing of only 1.5 millimeters or less in the common bile duct, or 1 millimeter or less in the common hepatic duct, or the left to right hepatic ducts. If found on MRI, proceed with ERCP with balloon dilation, especially if the patient has symptoms, and make sure also to perform biopsy and in situ hybridization to exclude cholangiocarcinoma. All patients should receive prophylactic antibiotics as well. Per the AASLD, routine stenting is not required after dilation. Many of the PSC patients are savvy in their disease, and they also are quite worried because of the fact that they are aware that there's no treatment on the market. I already talked about ursodiol not being recommended. So many of them end up being concerned, what's going to happen to me? And in order to counsel them, I tell them that I like to use the alkaline phosphatase and their changes in the alkaline phosphatase level as a marker of prognosis. So this is one of my favorite studies which evaluated the use of the alkaline phosphatase. It was a study of approximately 200 patients, and the initial purpose of the study was actually to evaluate the use of ursodiol as treatment for PSC. And they determined biochemical response as a normalization or reduction of alkaline phosphatase to 40% from baseline. And this is what was interesting. Okay, let's take a look at the first 2 curves versus the second 2 curves, of which the first 2 indicate greater survival. These included patients who received ursodiol or received placebo. And here's the point, is that regardless of whether you received ursodiol or not, or whether this was the natural history of your disease, if you've had a reduction in alkaline phosphatase to 40% from baseline, your transplant-free survival was significantly greater than if you did not have those findings. So again, the point is that regardless of whether you received ursodiol, if a patient has PSC and you see a reduction in alkaline phosphatase or normalization of alkaline phosphatase, you can counsel them that based on this study, their prognosis is better. This was another study which looked at a different surrogate endpoint of alkaline phosphatase less than 1.5 times the upper limit of normal. Because a patient may tell you, okay, my alkaline phosphatase has improved, but it isn't normal, should I be worried? So what this study found was that an alkaline phosphatase less than 1.5 times the upper limit of normal does indicate greater transplant-free survival as compared to greater than 1.5 times the upper limit of normal. Now here's the important point in this study. They similarly compared less than 1.5 times normal versus complete normalization of alkaline phosphatase. And what they found was that there was no difference in survival between these 2 groups. So if a patient does have improvement in alkaline phosphatase, and it's less than 1.5 times upper limit of normal based on this study, you can counsel them their prognosis is still good, even if the alkaline phosphatase did not fully normalize. So patients also ask about alternative therapies. Vancomycin has been studied for PSC, but again, these have been only small studies. Typically, vancomycin is given for 12 weeks, and the outcomes that are looked at include improvement in alkaline phosphatase, Mayo Clinic PSC risk score, and this was a review article which highlights some of these studies. The take-home message from this review article, though, was that even though there are studies available, more studies still need to be done before vancomycin can be routinely recommended. So when a patient does ask me about this, I don't recommend it as initiating therapy unless it's part of a clinical trial. Rifaximin, this was a small clinical trial, but I do want to highlight it because rifaximin is an antibiotic which actually does not have any bloodstream absorption and also does not have any association with bacterial resistance. So it seems like a safer medication to take. And it is a medicine we give in all our cirrhotic patients. But ultimately, in this small study, there was no improvement among patients taking rifaximin. PSC is an active area of research, so there's a number of clinical trials. I'm not going to go through all of these, but there's a variety of mechanisms by which companies are looking, including FXR agonism, VAP1 inhibition, there's a side chain derivative of ursodeoxycholic acid, antifibrotics, and ileal bile acid transport inhibitors. So there are a variety of trials. The majority of them are still in phase 2, but hopefully in the next 5 years or so we will have medications on the market which can finally treat this disease. So since there is no good medication to give for PSC, what is very important is the housekeeping, and in particular, that's the cancer screening. For patients who have concurrent inflammatory bowel disease, colonoscopy is recommended every 1 to 2 years. Similarly, for patients who have PSC who still have their gallbladder, because some of them may have had a cholecystectomy, you should screen with imaging of the gallbladder at least every year and perform a cholecystectomy if polyps are found which are greater than 8 millimeters in size. And this is from the AASLD guidelines, very supported. Now, many of you know that cholangiocarcinoma has a strong association with PSC, and a loose guideline has always been to perform an MRCP and a CA19-9 level every 6 to 12 months for cholangiocarcinoma screening, though there hasn't been strong evidence to support that. What I've typically done in my practice is performing both of these tests annually, and if there are changes in the MRCP or if the CA19-9 level is greater than 100, that's when I refer for ERCP with biopsy to evaluate for cholangiocarcinoma. In addition to that, patients should have an annual vitamin D level check due to the risk of osteoporosis and a DEXA scan every 2 to 4 years or every 1 to 2 years if they're above the age of 65. At one of my talks, one of the persons who's seen several of my talks that came up to me and said, you know, what I find interesting about you is that you always give your audience homework to do. So this is your homework. I mentioned before about cholangiocarcinoma screening and how there hasn't been good data on what to do with cholangiocarcinoma screening. So this is a paper which literally was just published this week in Hepatology. The lead author is Ali from Mayo Clinic, and this is a very nice retrospective study looking at hepatobiliary carcinoma surveillance. Their primary outcomes were the development of cholangiocarcinoma, gallbladder cancer, or HCC, and then ultimately survival from these cancers after the diagnosis. Here were their surveillance programs. For cholangiocarcinoma, this included any type of imaging, ultrasound, CT, or MRI, and a CA19-9 level every 12 months, so very similar to what the AASLD recommends. For gallbladder cancer, they did an ultrasound every 6 to 12 months, and then for HCC, the standard imaging and AFP every 6 months, but only if the patient had cirrhosis. If there was no established cirrhosis, you don't need to do HCC screening. What did they find? So approximately 10% of the 830 patients studied developed hepatobiliary cancer. And here was the breakdown of hepatobiliary cancer prevalence. 54 of those 79 patients, or approximately 70%, had cholangiocarcinoma. HCC was among 21%, and then gallbladder cancer, which was smaller prevalence but still there, was around 6%. Mixed HCC and cholangiocarcinoma was only around 3%. Furthermore, the median time from the diagnosis of PSC to the development of hepatobiliary cancer was 8 years. The range was anywhere from as little as 1 to as much as 27 years. So these are important points to keep in mind when counseling your patient. And this is one of the more important slides. Now, I don't have the time to go into all the nuances of this paper, but I think it's a very good paper which looks at a number of different, issues that we face as clinicians. But I think this one is an important point to highlight. And this looks at the development and survival of extrahepatic cholangiocarcinoma, which is really the big black box with PSC, and whether survival was better among those people who received surveillance as they defined versus those people who did not receive surveillance. And what they found was that among the people who did get surveillance, which was imaging plus CA 19-9 level once a year, the survival after diagnosis of an extrahepatic cholangiocarcinoma or recurrence of extrahepatic cholangiocarcinoma was significantly lower than death or cancer recurrence among the patients who didn't get surveillance. The reason why is that those who got surveilled, their cancer was diagnosed earlier, and as a result of that, they were able to get treated earlier. Also keep in mind that certain extrahepatic cholangiocarcinomas, such as perihilar cholangiocarcinomas, may be eligible for transplantation. So that's another reason for the importance of surveillance. In terms of what methodologies seem to be best for surveillance, for cholangiocarcinoma, the majority of the patients either had an ultrasound or an MRCP. The conclusions from these authors was that ultrasound was actually similar in terms of cholangiocarcinoma detection as MRCP was in combination with CA 19-9 level. Finally, the final thing I want to discuss briefly is IgG4-associated sclerosing cholangitis. So this is relatively rare, but the reason to highlight this is that there is a potential treatment for this disease if it's caught. Furthermore, the ACG guidelines are now recommending that all patients with suspected PSC should have a serum IgG4 test done on one occasion to assess for this. So IgG4-associated sclerosing cholangitis is an immune-mediated destruction of the intra and extrahepatic bile ducts, but it's characterized on histology by an abundance of IgG4-positive plasma cells in the bile duct wall. Some of the other distinguishing features, many of the patients with this also have autoimmune pancreatitis. Depending on what you read, it can be as much as 90%. 40 to 50% of these patients also have some history of allergy or elevated serum IgE levels. I have a patient, as an example, who has this diagnosis as demonstrated on biopsy, and he had hypereosinophilia, for which he saw multiple hematologists. He's now on appropriate medications as eosinophilia has completely improved. How do we diagnose this disease? Because once you get an IgG4 level, the question is, what do you do with it? So this algorithm, it's a little cumbersome, but the number to remember is essentially 1.4. If you double 1.4, that gives you 2.8, and if you double that, that gives you 5.6. If you can remember that, that can give you an idea. So if your IgG4 is greater than 5.6 grams per liter, then that is a lock-in diagnosis for IgG4-associated sclerosing cholangitis, and you can proceed with treatment. If the IgG4 level is less than 1.4 grams per liter, that pretty much locks in the diagnosis of PSC. And if it's between 1.4 to 5.6, that's where it gets a little more nuanced. But if it's between 1.4 to 2.8, then the recommendation is to check an IgG1 level and compare the IgG4 to IgG1 ratio before determining if the patient has PSC or not. Among the patients who have an elevated IgG4 between 2.8 and 5.6, the problem here is that although it can suggest IgG4-associated sclerosing cholangitis, keep in mind that cholangiocarcinoma can also lead to elevated serum IgG4 levels. So the recommendation based on this study is actually to consider an ERCP with biopsy to rule out cholangiocarcinoma. Treatment for this disease is prednisone. High doses of prednisone initially, though this can be tapered depending on the patient's response. But prednisone will have to be given for anywhere from 3 to 6 months. What I do is I not only assess the liver function test, but I also get a repeat cholangiogram. The recommendation from this review article is at 6 to 8 weeks. I usually give it at least 3 months before I get a repeat cholangiogram. And then if the patient is having a response, that's when you can initiate a prednisone taper. So in summary, Not all patients respond, with summary for PBC, not all patients with PBC respond to ursodeoxycholic acid, and prognosis is worse among non-responders. There are multiple scoring systems which are available. Try to keep in mind utilizing a scoring system which incorporates both ALK-Phos and bilirubin normalization. And then both obeticholic acid and bezafibrate in combination with ursodiol are available medicines in ursodiol non-responders. Summary for PSC: a reduction in alkaline phosphatase from 40% or from baseline or less than 1.5 times the upper limit of normal indicate improved survival and are good mechanisms by which you can counsel your patients. There's no treatment currently for PSC, a lot of research ongoing. Vancomycin may have a role in the future, but it's too early to tell right now. And most importantly, surveillance for hepatobiliary cancers, especially cholangiocarcinoma and gallbladder cancers, are necessary in the management of PSC. Thank you for your attention.